The next speaker for this pre-lunch session is Dr. B. Rajagopalan. He'll be talking to us on pulmonary tuberculosis current challenges. He is a professor in the Department of Chest and TB at Sri Ramachandra Medical College and Research Institute. Over to sir.
A very good afternoon to one and all of you. At the outset, I would like to thank the organizers of this meeting for giving me this opportunity to do this presentation. And I'm sorry, I think I am delaying your lunch by another half an hour to 45 minutes. Kindly bear with me. The topic I am going to deal is pulmonary tuberculosis today. What are the challenges in diagnosis and treatment? The objective of my presentation is to familiarize all the participants of today's program with the following thing. One, you must have a thorough understanding of the current scenario of the drug resistance in tuberculosis, because the main challenge of TB treatment today is the drug resistance. We should really know the current scenario and the problem of drug resistance. And when will you suspect drug resistance in your practice when you are treating tuberculosis? Third is how to diagnose drug resistance when you suspect. And to know the types of drug resistance, that is a familiarity of the different types of drug resistance is a must. And we should be thorough with the drugs available for treating this drug resistant TB, and also the basic principles of management of MDR and XDR tuberculosis. These are the objective of my presentation. Whenever I do a presentation on TB, I always start by giving a great tribute to this great person, Robert Koch, who has discovered Mycobacterium tuberculosis in 1882. TB was declared as a global emergency in 1993. It's almost 25 years have gone, and still we are having only a control program for TB. As for TB alone, see, we don't have an eradication program just like what we had for leprosy or smallpox and things like that. We still have only a control program, though we have declared this TB as a global emergency more than 3 decades ago. If you look at the current scenario, you have 9.2 million cases, new cases are occurring every year. 4.1 million new smear positive patients. They are very important, because every new smear positive patient in 1 year can infect almost 10 other people every year. So with that problem, we think of the problem, 4.1 new smear positive patients, and these patients are going in turn to infect 10 other people in every year. Think of the problem. And unfortunately, Asian BICIP countries, Burma, Bangladesh, India, China, Indonesia and Pakistan, we have the 48% of the global TB burden. It is very unfortunate. 1.7 million annual deaths are taking place, and 3.4 lakhs deaths are with HIV and co-infection. The real challenge is the problem of drug resistance. Look at the drug resistance scenario. Drug resistance is an increase in India. 2.3% of MDR in new smear positive patients. That is, every newly diagnosed smear positive patient, already 2 to 3% of them are MDR, multi-drug resistant. And 12 to 17% of the MDR in previously treated patients. Most of us in our practice, we see only about 50% of them will be new cases, and 50% already would have had treatment for tuberculosis. That is how we see in our practice. So just whenever the patient comes with a retreatment cases, when you see a retreatment case, 12 to 17 of them are MDR. It's very, very unfortunate. 2 to 3% of the MDR are already XDR. And 40,000 XDR are already reported across the 49 countries. And total drug resistance, almost 12 cases of total drug resistance were reported in India. So when you think of these deaths, annual deaths, so many deaths, every 2 minutes, 3 patients is dying of TB in India. Every 2 minutes, we lose 3 patients. That is how it happens. Think of HIV, the previous speaker, infectious disease person. He talked about H1N1. When one H1N1 dies in India, immediately it becomes a front page news in India. Even every country gives an advisory report of traveling to India, things, so many things goes on. But it is very unfortunate, every 2 minutes, in India we are losing 3 TB patients. So it is very important that every medical practitioner should have a thorough knowledge about treating tuberculosis. TB is one of the oldest diseases of the earth, caused by the most successful pathogen that has ever invaded a human being. It is also the most difficult disease to treat with multiple factors affecting the treatment outcome. This is what the WHO, when they started the DOTS program, they have said. And of the multiple important factors, most important thing is drug resistance. Showing drug resistance is not something new to Mycobacterium tuberculosis. Today, all the available evidence shows that drug resistance occurs only by mutation. All of you know mutation, what is? When 1 lakh bacilli, when 1 lakh bacteria is there, some of them about 10% or 12% or 15%. Some percentage will change its, modify its metabolism. That is what is called a mutation, that all of us have read in microbiology. So all the available evidence now shows that drug resistance in TB occurs only by mutation. Mutation is not something new to Mycobacterium tuberculosis. Mycobacterium genus is characteristic of slow mutation. This Mycobacterium tuberculosis genus itself is characteristic of even the present day Mycobacterium tuberculosis, which we are all treating and seeing in our practice, has originated by way of several mutations. About 115 million years ago, in Jurassic period, you have inferential evidence to say that this ulcerans, Mycobacterium ulceran, was present. This is about 150 million years ago. 3 million years ago, progenitors of the present day Mycobacterium tuberculosis affected the primates and hominids. Then the mutation continued. 15,000 years ago, presence of ancestors of the present day Mycobacterium, what we are seeing in our practice, affected our ancestors. You have all evidences for this. So this present day Mycobacterium, what we are all seeing in our practice, is only about 250 to 1000 years old. Whatever they have done, a carbon imprinting technology has been used on the mummies, Egyptian mummies. That was different from the present day Mycobacterium. So what happens, this present day Mycobacterium, which is about 1000 years old, man has invented this chemotherapy. So we started chemotherapy in a faulty way. So we have actually accelerated the mutation. This is what has happened, emergence of several drug resistance genes. Otherwise, what would have been a slow process, by the advent of this chemotherapy, we have accelerated the emergence of drug resistance. HIV has come in between in 80s. So that has still worsened the scenario of drug resistance. Are we heading for a drug resistance epidemic? Probably yes. Maybe 20 to 30 years from now, you may not be having all this AKT regimen, rifampicin, INH, what we are using. Maybe you will be seeing more and more of drug resistance rather than this. Please remember this. So when you look at the genesis of multi-drug resistant tuberculosis, I told you resistance is a man-made amplification of the natural phenomenon. Naturally, this Mycobacterium was having some mutation. By introducing this chemotherapy, we have amplified the natural phenomenon. Inadequate drug delivery is the main cause of secondary drug resistance. What is inadequate delivery what do you mean by inadequate delivery? One, patient not taking the drug properly, Number two, most important, first and foremost, is giving a wrong prescription to the patient. So that is the main cause of secondary drug resistance. Please remember. And secondary resistance is the main cause of primary drug resistance. Transmission. When a person develops a secondary drug resistance by a faulty chemotherapy, faulty prescription, or chronic defaulting, then he is going to develop a secondary drug resistance, and in turn he is going to spread the disease to another person, which will end up as a primary drug resistance for him. So, and please remember the last point, MDR due to spontaneous mutation is not possible, because a gene coding resistance for anti-tuberculosis drugs are uncoded. So most of the time when the patient comes with a MDR and XDR, it is purely a man-made phenomenon. We cannot find fault with the bug. Please remember that. So what is drug resistance? If you ask a microbiologist, they will give this definition: temporary or permanent capacity of the organism and the progeny to remain viable or to multiply in the presence of a concentration of the drug that would normally destroy or inhibit the growth. So this is the microbiologist definition. So the organism starts growing in the presence of the drugs that is supposed to suppress the growth. That is what is the microbiologist definition. But if you ask the clinician, when the patient is not showing improvement even after taking a drug, that is supposed to give him a cure. The previous speaker has told about the drugs. Okay, these are the drugs that will work on such and such organism. So we know when we suspect TB, when you give some drugs, the patient is supposed to improve. If he doesn't improve, then probably we are having a drug resistance. That is how you suspect drug resistance. But in tuberculosis, it is a chronic disease wherein you need a prolonged treatment. Then when will you suspect resistance? It is not like community acquired pneumonia wherein you said you give only 72 hours of treatment once when there is a clinical improvement. It is not so. TB itself is a chronic disease. We are going to give treatment for minimum 6 months, it will go up to 18 months and all. Then when will you suspect resistance? When a patient is having an unfavorable clinical, radiological or bacteriological response, even after taking an appropriate chemotherapy for an adequate period of time. Here, these two words are very important for the postgraduates. Okay. What is an appropriate chemotherapy and what is an adequate period of time? Appropriate chemotherapy is when a patient is having an extensive disease, we are supposed to give more drugs. All of you will be familiar with category 1, 2 and 3. In category 1 you have only 4 drugs. In category 2 you have 5 drugs. Then category 3 you have only 3 drugs. Why is it? It is all because of the extent of the disease. So giving a patient is having an extensive disease, you are giving less drugs, 2 drugs or 3 drugs, that is not an appropriate chemotherapy. Okay. So then you are giving for an extensive disease, you are giving only INH and ethambutol and patient is not showing improvement, immediately you cannot think of drug resistance. Here the treatment is it was a faulty treatment. Then adequate period of time, then again it varies. When you are giving a rifampicin containing regimen, you expect some improvement much earlier. When the patient is given a non-rifampicin containing regimen, then you have to wait for more time. Immediately thinking of drug resistance, because every time when we see the patient, they give a referral to the chest OP. Patient would have started with some weak extensive disease, they would have started with some weak regimen, that too not a proper dosage. They would not have given a proper dosage. 15 days later, patient not showing improvement, fever is not coming out. We are referring this patient as an MDR TB. That should not be done. Okay. So please remember this. What is an appropriate? I told you, right regimen. You have to give a right regimen, right dosage. That is very important. Fixed, especially all these kits, these AKTs, all these things have spoiled. We don't think about the dosage at all. We simply write something. So you have to give the right dosage. That is very important, and right duration. That is appropriate. Adequate, it is variable depending upon the regimen. I have already told you. Okay. when for some reason, for example, a patient who has a hepatic disease, you are not giving rifampicin or isoniazid. For that, we have to give the extended period. If you are giving ethambutol, araquinolone, or an aminoglycoside, you have to give for more than a year. Okay, in such patients, you cannot immediately think of drug resistance after. So please remember this slide. So this will tell you when to suspect drug resistance in your day-to-day practice when you are dealing with a patient, TB patient. Is clinical worsening is always due to drug resistance? You are starting somebody with a anti-tuberculosis treatment. Patient is not improving clinically. It is not always. Again, I told you, please remember, check the regimen. Check if the patient is getting a proper regimen. Review your diagnosis. It may not be TB also. Simply we would have started with the tuberculosis. Okay. Look for the comorbids. Very, very important. In tuberculosis, suppose in the patient is having diabetes or HIV co-infection, the patient is not going to improve. So think of the comorbidities. Okay. Repeat the sputum microscopy. In that way, you make sure that what you are dealing is only tuberculosis. Okay. Then think of iris. What is iris? Immune restitution, inflammatory syndrome. Okay. In that case also, patient might have a worsening of symptom. You think of that. Immediately don't go and change the drug or add one more drug. That should not be done. So clinical worsening is not always due to drug resistance. Is radiological worsening is due to drug resistance? Again, it is not so. You have to again check the regimen, because another problem. People just keep, the patient will be referred with the X-ray taken every week, 4 or 5 X-ray. They would have started ATT with only 1 month or so, but patient will be having at least 4 or 5 X-rays with him. That should not be done. Repeating X-ray for a TB patient before 6 weeks of proper treatment is not correct. Okay, so it is not so. You have to again review the diagnosis, look for the comorbid, repeat the sputum and iris. Sometimes patient will have a clinical improvement. This you see in our day-to-day practice. Patient will have shown a very good improvement. The fever would have come down, but the practitioner would have unnecessarily written an X-ray. If you see the X-ray, there will be worsening. The X-ray report will say there is a clinical worsening compared to the previous X-ray. That is again you have to think of iris only and think of a HIV co-infection. Is bacteriological worsening is due to drug resistance? That is a failure or delay in sputum conversion. You do a sputum examination positive, 2 to 3 months later you are doing a repeat sputum examination, it is again positive. You think of drug resistance? Probably yes. So drug resistant you have to suspect only with the bacteriological proof. Please remember this. Still you have to check the regimen, look for the comorbids and confirm by drug sensitivity testing. DST is drug sensitivity testing. Okay. This is how you think of drug resistance. So in our day-to-day practice, we cannot be thinking of all those things. When you are seeing a new patient, patient is coming to you for the first time, to you, maybe you would have had treatment elsewhere also. When you will suspect drug resistance, prior treatment, anybody who gives a history of prior anti-tuberculosis treatment, please think of drug resistance. Non-adherence and default, usually invariably the attender will tell, oh he was diagnosed to have TB 2 years back, he didn't take a proper treatment. Then last year also he was started on treatment, he took only for a short period. All those history will tell, non-adherence and default, you have to think of drug resistance. Exposure to possible drug resistance source case. If somebody says, oh this patient, father had a multi-drug resistant tuberculosis, then you have to think of, simply start, you should not start them at a category 1 or so, you have to think of drug resistance. And patient coming from a community prevalence in drug resistance, very, very important. All these patients, we see lot of such patients in this category. In Chennai, you have so many workers, all this metro rail project has brought in all these BREs and from northeastern states, where the drug resistance, the problem of drug resistance is more. When we see a patient from that area, you have to think of drug resistance. of late we are seeing so many of the workers coming from the Bihar and from northeast eastern states. They come here, so we find this. Suspecting drug resistance in RNTCP. You all have, you must be very, what is another important thing is familiarity with the, you may be a general private practitioner, you may be working in a corporate sector, but everybody should be familiar with the national program, RNTCP. That is very important. Okay. I think you should all be familiar with the criteria A, B and C. Here, what is important in this part, in Tamil Nadu and all is criteria B. All the smear positive patients, retreatment pulmonary patient at the diagnosis, or any of the smear positive follow up in new cases or retreatment cases in addition. All these patients, you should suspect drug resistance. And they should have a drug sensitivity testing done before starting them with anti-tuberculosis treatment. It's very, very important. So, these definitions, all of you, especially the postgraduate students, should be familiar. I think all of you know this. Monoresistance is resistant to a single primary drug. Okay, any one of the first line drugs. If somebody is resistant, it is a monoresistant. Polyresistant, resistant to more than one drug, but not to the combination of isoniazid and rifampicin. Patient may have resistance to more than one drug, 2 drug, 3 drug, anything, but he should not be resistant to INH and rifampicin together. That is polyresistant. Multi-drug resistance is resistant to again more than one drug and resistant to isoniazid and rifampicin with or without resistance to the other drug. It's important. When you say drug MDR, patient should be having resistant to INH, rifampicin with or without resistance to the other drug. Then XDR, extensively drug resistant, MDR plus resistance to fluoroquinolone and at least one of the 3 injectable drugs, amikacin, kanamycin and capreomycin. Okay. So, this is also becoming a problem in India, XDR, directly XDR, because the previous speaker has highlighted about the misuse of quinolones in Indian scenario. Patient simply they start taking quinolones. Every time the patient gets go to a doctor, they write a quinolone. So, directly we are seeing an XDR in some of this. Okay. So, please be thorough with all the definition. Once when you suspect, drug sensitivity testing should be done. Drug resistance can be classified only according to this. Whether it is a monoresistant, polyresistant, MDR or XDR, you can do that only with a DST testing in hand. Simply clinically you cannot make a diagnosis. So, when you diagnose drug resistant, suspicion clinical, you can suspect clinically, but confirmation only by culture sensitivity. Very important, please remember, it is not a clinical diagnosis, drug resistant, it is a laboratory diagnosis only. So, how reliable are the drug susceptibility testing? It is another thing, because we have these laboratories in every state. We have 2 or 3 laboratories. Every lab they have their own testing facility. So, they come out with so many newer tests, but how reliable are they? Conventional LJ medium culture is the gold standard. Please remember, all of us have read from our undergraduate LJ medium. That is the gold standard. You have the newer test MG80-960 non-radiometric culture. It is faster, reliable, but very expensive. It is also reliable test. The MG80-960. You can so it takes about 2 weeks or so. Okay. Then MODS is cost effective, laborious, risk of cross contamination is there. The other molecular test, lane probe assay, which is widely being used in program condition in India, National TB Control, PMDT, it follows only the lane probe assay. It is very fast, reliable. You can get the report within 3 to 5 days. It is costly and detects isoniazid and rifampicin resistance, that is MDR resistance. Gene expert, this is another test, that's also a very reliable test. You know whether you are dealing with a rifampicin resistant or not in just 2 hours time. So that is also a thing, but again it is very expensive, not available everywhere. You have another Hain genotype, MDR, XDR, say this is also faster, but all these things are costlier. That is one thing. So, and it has to be supported by the conventional culture. You may have so many new tests are available, but when you are asking for the test in your day-to-day practice, please also ask for the conventional culture. Though it is going to take some time, but you will know whether you are going in a right direction or not. Okay, so the gold standard is only the conventional LJ medium culture. Consequences of inaccurate drug susceptibility testing. This is what will happen if you are going to do it in a lab wherein they don't follow the proper quality assurance. Then it will end up with this unnecessary misclassification of the stain, unnecessary change of regimen. You will have the unnecessary use of the reserved drug, higher toxicity. Most of these drugs are very highly toxic drugs, the second line drugs. Less chance of cure and cost, of course. So, excuse me. So, all these rapid tests, the newer tests, MGIT, line probe assay, gene expert, are they really game changers in tuberculosis diagnosis? Yes, it is. Because drug resistance is an increase, and now we are in a situation we need to not only just the diagnosis of TB, but also the drug sensitivity testing for effective treatment. Otherwise, you will be just treating them as unnecessary drug regimen. So, next part of the presentation is going to be how you are going to treat this drug resistance. For that, you should be familiar with the drugs available for treating this drug resistance, general principles and treatment of the individual, that 4 types of drug resistance what I have mentioned. Management of drug resistance should always be patient-centered measure. It should be comfortable to the patient because we need the patient cooperation. So, directly observed treatment is required to ensure adherence, very, very important. If you are just going to give the drugs to the patient because of the toxicity, because of the side effects and the cost, the patient may not take the treatment properly. So, it should be directly observed only. Consultation with an experienced TB specialist is a must. Simply because after attending this class, evening you cannot go and start treating a drug resistant TB. It cannot be done. We have studied about the classification of anti-TB drugs. Previously, there was a classification called primary drugs and second line drugs, first line drugs and second line drugs. The previous classification of first line drugs is streptomycin, isoniazid, rifampicin, ethambutol and pyrazanamide. These 5 drugs were called first line drugs, and all the other drugs were called a second line drug, but that classification is no longer used. WHO has clearly classified the TB drugs in this following 5 groups. You have a group 1 drug, first line drug, isoniazid, rifampicin, ethambutol and pyrazanamide. Streptomycin is removed there. It is not there in the first group 1. Group 2 is injectables, kanamycin, amikacin, caprimycin and streptomycin. Please remember, they have made it as a injectable. They have not mentioned for the postgraduate. It is not aminoglycosides. Because why? One of the drug is not an aminoglycoside. Caprimycin is not an aminoglycoside. That is the reason you have to use the terminology injectable when it comes to group 2. Right? Group 3 is fluoroquinolones, levofloxacin, moxifloxacin, ofloxacin. Again, please see that ciprofloxacin is not added here. Cipro is no longer considered as a anti-TB drug. Okay. So, only these 3 quinolones, respiratory quinolones, Even if short notes is asked about respiratory quinolones, you have to write about only these 3. Okay. Then group 4 is oral bacteriostatic drugs, ethionamide, cycloserine, PAS, prothionamide and the other one. Last is the group 5, unclear role. You have the clofazimine, linezolid, amoxicillin clavulanic acid, imipenem cilastatin, thiazidone and high dose of isoniazid and clarithromycin. Okay. Please remember, all these drugs also have an anti-TB drugs. The previous, in the previous speaker was talking only about quinolone, but many times in the ICU we use some of these drugs for treating pneumonia. I always think when the patient is having a thing, do a sputum A, B, we rule out TB first and foremost thing, because when the patient is started with this amoxicillin clavulanic acid and clarithromycin combination, they will improve. Even a TB patient will show some improvement. Okay. Don't think of only quinolone. Think of all these other drugs also. Okay. All of you have to just memorize it. Have it as a photo memory. These 5 groups of drugs. What are the drugs in these 5 groups? Because only this will help you to give a proper prescription. So these are the principles. When you are suspecting TB, you have to use at least 4 drugs likely to be effective or not used earlier when you suspect. Do not use the drug which have a cross resistance. For example, in the previous thing, so all these are quinolones only. For the same patient, I cannot write levofloxacin and moxifloxacin. Why I am telling is, we have seen prescription. Same patient getting 2 quinolones. Okay. So that should not be there. Then again, aminoglycoside, streptomycin and kanamycin, we cannot give together. Recently, I saw in one of the ICUs, wherein patient was given amikacin for some other thing, they suspected TB and then started with streptomycin also. That should not be there. So please remember that that should not be done. You should not use the drug which have a cross resistance. Include groups, drugs in the group in 1 to 5 in a hierarchical order based on the potency. Very important. Only when you remember those 5 groups, you will start. Once you start prescription, you think of the first one. Okay, first one, you have INS, rifampicin, pyrazinamide, ethambutol. You have to use the drugs. Then injectable, then quinolone. Like that only it should be done. Avoid drugs that are not safe for an individual. Another important thing. When you find that, for example, a patient, very elderly patient, we cannot give a high dose of ethambutol. Patient is having a renal problem, you cannot give an aminoglycoside. All those things we should remember. And you should be very thorough with adverse drug reaction. Very, very important. When you know about these drugs, whenever you read about the drugs, you be thorough with adverse drug reaction. You should know the absolute contraindication. Any drug, is there an absolute contraindication for that? Because recently it was very pathetic. There was a patient who came with a lot of purpuric lady, say 18-year-old girl. She came with a lot of purpuric spots on her. She was on an anti-tuberculosis treatment. The lady has developed this following a start of AKT. She has gone and told the doctor that the reddish color has come on her body, on her skin. The doctor has said, no, the rifampicin will produce that color. When we checked the platelet, she had a platelet count of 2000. Because rifampicin is the one that produces thrombocytopenia. The patient has identified and told, but just like rifampicin producing a dark color urine, this practitioner probably thought this reddish color also is due to rifampicin. This was the answer given to it. So we all should be very thorough with the adverse drug reaction of each and every drug. Okay. Additional important features. Use a direct observation treatment. I already told you. Use daily regimen. You would have read about intermittent regimen in the program. You give three times in a week we are giving, but that should not be the case when you are suspecting drug resistance. Treatment duration, again it should be for a minimum period of 18 to 24 months. Minimum duration should be 18 to 24 months. Whenever possible, continue the injection for a maximum of 6 months. Because another problem is when you are treating a MDR, when you are giving an injectable, every time the patient comes to you, they will ask when you are going to stop the injection. So just because the patient is asking, we cannot stop the injection. The injectable should be used at least for 6 months, minimum 6 months, or at least 4 months after the culture has got converted. Continue at least 3 oral drugs for the full treatment, that is 18 to 24 months we should use. So non-MDR, I told about this poly drug resistance, very simple to treat. When the patient is having only INH resistance, you have to give rifampicin, ethambutol and pyrazinamide 6 to 9 months. INH ethambutol, again the duration is only less than 1 year. You can use your rifampicin, pyrazinamide, fluoroquinolone and injectable. I already told you the rules, what you should do. You use at least 3 or 4 drugs which the patient has not got exposed to earlier. This is how you should be. Rifampicin resistance, again just see, whenever you are using a when you are having a non-rifampicin regimen, the treatment duration should be for 18 months. Please remember that. There is no non-rifampicin containing regimen which is given for less than 18 months. Right? Then rifampicin ethambutol resistance, again you use some drugs, but the duration should be for about 18 months. Right? So these are the 3 steps by which you can write a prescription. Step 1 is use all the first line drugs which was not used earlier. When you are suspecting an MDR or an XDR, use all the first line drugs which are not used earlier, and injectable drugs for a minimum of 6 months or 4 months from the sputum conversion, plus oral fluoroquinolone. This is step 1. So in that way you are exhausting all the group A, group B and group C drugs. Okay. Then step 2 is you add 2 or more of the group 4 drugs. Prothionamide, ethionamide, cycloserine, PAS. You can use either 2 or more. Finally, if you are not getting an adequate number, total number into 5, then you start adding from the group 5. Immediately don't write clarithromycin because that is a group 5 drug. Okay. When you cannot make up total 5 from this group, then you have to add from the thing. That should be the step 3. Okay. Total duration of treatment 18 months after sputum conversion. Please remember. Do a periodic sputum examination. When this MDR XDR patient becomes negative, from that date onwards you have to do 18 months of treatment. 24 months for a chronic and extensive pulmonary damage. When the patient is having extensive pulmonary damage, sometimes the patient will have a smear negativity, but if you look at the X-ray, there won't be any lung parenchyma at all. In that situation you have to give for 24 months. So individual treatment for MDR, this is designed according to the individual drug resistance. Once you have, I told you, see, by lane probe assay, by gene expert, you can only make out INH and rifampicin resistance. Only by way of conventional culture, you will know the resistance to the other drugs. So once that is ready, you change the regimen according to that. This is what I am trying to tell by this. Same principle as the empirical regimen, advantage unnecessary toxicity. Unnecessarily, suppose if the patient is having ethionamide resistance from the conventional culture, then we need not give ethionamide to that patient. So unnecessary toxic and expensive drugs which are not sensitive can be avoided by this. So factors responsible for development of XDR. Again, faulty treatment, non-adherence to the treatment, erratic use and poor quality of second line drug. This is another problem in India. We have most of the second line drugs, they come from a pharma company who don't have a proper manufacturing facility. They get raw material from all the I don't want to mention some other countries, and we are getting a very poor quality of it. That is one of the reasons for the development of XDR. Lack of experience in managing drug resistance, poor control practice. These are all the common causes for development of XDR TB. Again, XDR same as MDR. First you have to use drugs from the group 1, which is very unlikely. XDR, you don't expect a patient to be having sensitive to INH, rifampicin or pyrazinamide ethambutol. Very unlikely. Use an injectable for 12 months throughout the treatment. If resistant to all injectables, please look at this point 3. Even if the patient is resistant to all the injectable as per the program, we cannot just write off the patient. Oh, XDR, let the patient go away. We have to give the drug which was not used earlier or the highest injectable. That is, what is the highest injectable in that group? Caprimycin can be used in XDR. Then use the lateral fluoroquinolones, even if the quinolone resistance. Highest fluoroquinolone is the moxifloxacin. Even if the patient is resistant to moxifloxacin, we have to use moxifloxacin when you are treating with the XDR TB. Use all the 4 agents that are not used extensively. Use any of the 2 or 3 from group 5. High dose of isoniazid. This is also very important. You can give, instead of 300 milligram isoniazid, you can give 600 milligram daily. That will also to some extent help. Adjuvant surgical option has to be ensure strong infection control. These are the basic principles for treating an MDR, XDR TB. Drug contraindication, known severe drug allergy. When a patient is having a severe drug allergy, we are not supposed to use the unmanageable drug intolerance. Sometimes the patient may not tolerate. PAs you give, they will vomit, they won't be able to take the drugs despite other supportive measures. Then you have to avoid that. Risk of TV toxicity with the symptoms such as renal failure, hepatitis, hearing loss, depression, psychosis, we cannot use the drugs. Drugs of unknown quality, I already told about this quality, how important is the quality of adjuvant therapies. These are the adjuvant drugs therapy, because invariably the patient will ask, once you write the prescription, then the next thing they will ask is about the nutrition and the supportive treatment. These are the common adjuvant. You can ask the patient to take plenty of staple food and source protein. B6 supplement is very, very important. Benadryl, you give 40 milligram. Cycloserine, iodocyanide. Remember, zinc, iron, calcium interfere with the absorption of quinolone. Please remember this. You can use this in we don't practice in your day-to-day practice also. You write a quinolone, ciprofloxacin, along with that you write a zinc preparation. We will write zinc of it. That will interfere with the absorption of quinolone. Please remember. We are not supposed to use a zinc, iron or calcium when a patient is given a quinolone. Corticosteroids in respiratory failure and CNS thing. So this is for the benefit of the postgraduate students. I have put up this. Building a regimen for MDR and XDR. Same thing. Step 1, I told you. Use any of the available first line drugs. Invariably, when it is MDR or XDR, patient is resistant to INH and rifampicin. Okay. So what you have to use is either a pyrazinamide or a ethambutol. You ask the patient, find out the history. If the patient has not taken, usually invariably patient would have taken pyrazinamide only during the intensive phase. 2 to 3 months only you would have taken. So we can take pyrazinamide as one of the drugs. Then add a fluoroquinolone, levofloxacin, moxifloxacin or ofloxacin, whichever is available. But best is to use the higher quinolone, moxifloxacin or a levofloxacin. Then you have to add injectable, amikacin, caprimycin, streptomycin, kanamycin. Of this, the best choice will be kanamycin, because that is the only injection that can be given thrice a week. All other injectable should be, streptomycin is out. So this amikacin and caprimycin has to be given daily. So kanamycin can be given intermittently. So this is step 1. Step 2 is you pick up any one of these second line drugs, cycloserine, ethionamide and PAS. Select any one or 2. If possible, you can even select any 3 of these drugs, because these drugs will have a definite action against mycobacteria, drug resistant bacilli. Step 3 is selecting from the group 5 drugs. Clofazimine, linezolid, amoxicillin, clavulanic, imipenem and clarithromycin. So this should be step 3. And finally, you should make it into minimum of a 5 drug regimen. This is how you make up build a regimen for MDR and XDR. Okay, MDR. XDR again, see first line very unlikely. Fluoroquinolone by definition it is resistant, but still we have to use a moxifloxacin when you are writing a prescription for XDR TB. Okay, injectable again by definition they are resistant, but still we can use an injection which the patient has not had earlier. Most probably the choice will end up with a capreomycin when you are writing an XDR prescription. Then of course you can select any one from this drug, and most of the time you may require all the 3 drugs when you are writing an XDR prescription. Then of course you have to use the other drugs. I told you this group 5 drugs should be the last choice, because invariably we see amoxicillin, clavulanic acid, linezolid and clarithromycin is being extensively used when it comes to drug resistant TB. So these are I already told about the management principles. It should be central. So what is the advantage of a direct observation? If you see self administration, see there is, look at the relapse. When with the dots it is very much less. MDR relapse is about 20.9% when the patient is allowed to take the drugs on his own. But whereas if it is under direct supervision, it is only 5.5%. So this is the important. And common side effects, I will end up with this. You should know what are all the common side effects of the drugs. I told you about the common side effects. Familiarity is very, very important. GAS disturbance, ethionamide, cycloserine, PAS, fluoroquinolones, clofazimine, rifabutin. Hepatotoxicity, INH, rifampicin, ethionamide, pyrazinamide, PAS, fluoroquinolones. Interesting, please note this. Usually when you have a hepatotoxicity, we give a regimen containing fluoroquinolone. But 20% of the patient, fluoroquinolone per se can cause hepatotoxicity. So you should remember that. Peripheral neuropathy is not INH alone. Ethionamide, cycloserine, linezolid and ethambutol. Ethambutol can also cause peripheral neuropathy. So of course, very simple. All you have to do is give your vitamin B6, rash, all, headache, again fluoroquinolones, acid, cycloserine, ethionamide, ethambutol, seizure, cycloserine and INH can cause seizure. Hypothyroidism, ethionamide and PAS, hearing loss, aminoglycoside and capreomycin, behavioral changes, any cycloserine, ethionamide, isoniazid and fluoroquinolone can cause a thing. Visual change, ethambutol, rifabutin, isoniazid and linezolid, all these things. Usually when there is a visual change, we think only about ethambutol as a culprit, but other things can also cause the thing. So just to summarize, is a real threat to the national program. Whenever you suspect drug resistant TB, immediately ask for the drug sensitivity testing. Many of the drug sensitivity testing are too costly and unproven. Conventional, please remember, conventional culture is a gold standard. Treatment of MDR is costly and complex, and it is easier to prevent MDR and XDR than it is more difficult to treat them. Expert consultation is a must. I already told you about the adverse side effects of the drug should be common. You should remember all these things. Strictly follow the treatment guidelines, and I told you already you must be very familiar with the TB control program in your area. To conclude, let me finish with this. While treating a disease, make a habit of 2 things. One is to help or at least do no harm. Very, very important. In fact, there are 2 things, science and opinion. The former begets knowledge and later ignorance. Please read about everything. Okay, just don't give opinion. Many times we think we are giving a perfect opinion. It is not so. Unless you have a clear scientific knowledge, we cannot give opinion. So in that way, please refer to the patient, to an expert in that field whenever you have in doubt. Thank you.
Great session and a small token of